Hey, welcome to everybody joining. We're going to give everybody a few minutes to hop on here. And we'll just start by welcoming National Academies, our panel today. We're thrilled to have everybody here. Alex Christ, Jeanette Southpaul, Andrew Bazemore, Sarah Singer, and Harold Cudler. We're going to begin on time. I know people are going to be joining a bit after the hour, so we'll just give everybody about 1 minute to get on, and then we will start with a few updates from AIHM, and then we will jump into the presentation. Okay, so just a reminder as well to everyone joining, we'll announce this a couple times throughout the webinar, but you'll be able to put your questions for the panel into the chat. And then at the end, we will save a few minutes, probably about 10 minutes, that we'll read the questions to the panel and they can answer. And these will also be answered in our Facebook Live as well as our LinkedIn Live. And those will live up there for 24 hours. And then this is also being recorded. So you'll be able to view this webinar after for indefinitely on our YouTube channel. And everyone who attended this webinar will get the links to all of those things. So we're going to get started since it is noon Pacific, 3 o'clock Eastern. And just for anyone who doesn't know who's joining this new, the Academy of Integrative Health and Medicine is a global interprofessional integrative health association working to transform healthcare, body, mind, spirit, community, and planet. And AIHM is coming up on our 10-year anniversary, which will be next year, which is very exciting. We're going to be doing a lot of promotion and special events leading up to that through 2024, and they will all kick off at our October conference. AIHM is made up of individual members, organizational members, global agencies, researchers, the industry, and other sponsors. So there are plenty of ways for anyone to get involved. It is not just through our fellowship, but there are many different ways you can get involved with AIHM. So it always helps to just reach out and talk to someone. Our fellowship has a special offer going on right now for our October cohort, which starts October 2nd, which is right before our annual conference in October. So if you apply by June 18th and you pay your admissions fee by July 4th, which is coming up next week, your ticket to AIHM's annual conference is on us. So you can always reach out to someone in fellowship or marketing, and we'd be happy to discuss further with you. Again, here is some more detail about our presenting guests. This will all be recorded and sent to everybody, so you don't need to read through this too quickly. We just wanted to thank everyone for being here, and we can get into why you're all joining today with the presentation. So I will stop my share.
Hello, everyone. Thanks for welcoming my colleagues and me to your webinar today. I'm Jeanette Southpaul. I'm the provost at Meharry Medical College in Nashville, Tennessee, and a family physician. And my co-chair is Alex Christ, who's also a professor of family medicine at Virginia Commonwealth University. Here you'll see the expert study committee that was convened to assess this model national program. You'll see there were 18 members of that committee. When you look at the expertise of the committee, you see that it spanned many sectors, backgrounds, and skills. And there are complete bios that are in the appendix A of the report, so you can see more detail, the skill set that we brought to this work. Our committee could not have completed this work and produced the final report without the excellent NAM professional team who worked tirelessly to facilitate this effort. Study Director, Mark Meisner, Research Associate, Marjani Cephas, our Senior Board Director, Cheryl Nass, and our National Academy of Medicine Fellow, Dr. Alexander Melamed. The committee and the National Academies are grateful to the 3 study sponsors for supporting this important work for both veterans and the nation: the U.S. Department of Veteran Affairs, the Samueli Foundation, and the Whole Health Institute. As with all consensus studies at the National Academies, the statement of task defines the work of the study committee. The committee must address the statement of task, but cannot go beyond it. The committee was charged with examining the potential for improving outcomes through a whole healthcare model. As we will discuss in more detail a bit later, this is a people-centered, integrative approach to health creation and well-being by incorporating patients' goals and priorities into their healthcare decisions while still providing high-quality disease management. The committee looked at the VA's existing whole health system and other systems implementing whole health-like models and considered ways to scale and spread whole health nationwide for everyone in and out of VA. In particular, the committee considered where is whole health currently being implemented? What does whole health accomplish at VA and in other systems? How can effective whole health strategies spread? And what other factors affect the performance of whole health? It is important to note that the study and its recommendations are not for VA and veterans only. But because the committee was specifically asked to include findings and recommendations for future directions and priorities for the VA and other health systems that are caring for veterans in implementing this system of whole health population health care, this all naturally includes all health systems. That's because there are nearly 20 million veterans, more than half of which are not enrolled in VA healthcare, therefore likely receiving their care in the private health sector. The committee process included 6 meetings, 4 of which were virtual, and all of which were 2 days. They included 2 public sessions, one where we heard from the sponsors, and the other where we heard from health systems and various approaches to health and well-being that are important aspects of whole health models, but generally not well integrated into conventional medical care. For example, things like spiritual care, complementary and integrative health approaches, social determinants of health, and the like. We commissioned 3 papers. One focused on the evidence on patient-centeredness. The second focused on the VA whole health implementation, research, and future directions. And then the third on lessons from whole health from other health systems. The list of reviewers is available in the front matter of their report. These recommendations that we present were driven by consensus, and then there was external peer review by 10 experts in a variety of disciplines. I'll now turn our discussion over to my co-chair, Alex Christ.
Thanks, Jeanette. So the context of this study is that by most measures, healthcare and health outcomes in the United States are not in great shape. So despite spending more than other OECD countries on healthcare, we still have worse health outcomes. And the US life expectancy is lower than other countries, and it's getting worse. Adding to this, the US has large racial and ethnic disparities, and the average life expectancy can differ by as much as 18 years, depending on where you live and your race and your ethnicity. The US's poor health outcomes are not surprising, though. Our health system is focused much more on medical treatment of health problems after they've arisen. We don't do well with proactive health creation. It's undervalued, it's underfunded, and it's under-resourced. An added problem is that conventional healthcare is siloed and fragmented, and the fragmentation gets worse when we're trying to address the root causes of poor health, specifically the social determinants of health and factors like health behaviors, mental health, and social needs. The VA, and one of the reasons that this report is grounded in the VA, is that they've been a leader in the whole health movement in rethinking what health is and how to help people achieve it. And this aligns with the VA's charge to innovate and improve health for veterans who've served our country. The VA is a unique system, and it's more flexible than many health systems that mostly rely on fee-for-service payment. It provides both conventional medical services, but it also provides social services. Now, if we want veterans to receive whole health care, we need to extend whole health innovations beyond the VA, as many veterans are not enrolled in VA care. And that's why this report is about helping veterans to achieve whole health and the nation to achieve whole health, because all people deserve access to and the benefits of whole health care. So this applies to the veterans, and it applies to every health system in the US. The first task of the committee was to define what whole health is and what's required to deliver whole health care. And this shaped the whole report. We did this by drawing on existing definitions and existing examples of whole health approaches. And the committee's definition of whole health care is that whole health is physical, behavioral, spiritual, and socioeconomic well-being as defined by individuals, families, and communities. And to achieve this, whole health care is an interprofessional, team-based approach anchored in trusted longitudinal relationships to promote resilience, prevent disease, and restore health. And it aligns with a person's life mission, aspiration, and purpose. So having whole health is fundamentally different from being healthy in the traditional biomedical model. And the committee believes that every person and all people and all communities have a right to whole health, and we considered it a common good. In addition to the definition, the committee identified 5 foundational elements that effective whole health care systems need to address. And the report details the evidence supporting each of these elements and what they mean for a whole health system. I'm going to turn things over to Andrew now, who will present the high-level review of these different elements.
Thanks, Alex. Yeah, the committee began at the top list element that is the driving backbone of any health system is people-centeredness. And in short, what they meant was that people and families and communities would be empowered to direct the goals of their care. But a step further, it also meant that the care had to be delivered in a social and cultural context of those people, families, and communities in a way that aligns with their values. And finally, needed to be built on long-term relationships that are critical to fostering a sense of purpose, of shared direction, which collectively are essential to achieving whole health. Second, whole health approaches must be comprehensive and holistic. They have to attend to the entirety of a person, family, or community state of being. And they really need to address all of the domains that affect health and whole health: acute care, chronic care, preventive care, oral health, vision, hearing, the promotion of healthy behaviors, addressing mental health, integrative medicine, social care, and spiritual care, and with components and team members that were well integrated and coordinated. Third, whole health systems have to direct their attention not only to the problem in front of them, but have to direct their focus upstream. And to do so, they need to be multi-sectoral, integrated, and coordinated so that they can identify and address root causes of poor health. They also have to address the structures, the conditions of daily life that make them conducive to whole health. And again, this requires collaboration across sectors, including with many folks who typically operate outside of healthcare in most community settings. Whole health also needs to be accountable for the health and the well-being of the people, the families, and the communities served. That involves and requires community engagement, full participation in system governance, and in that instance, ensuring accountability. And it needs to be accessible and high quality for all. Finally, the health and the well-being of the care delivery team is critical and must be fully supported in whole health systems. This means encouraging, fostering positive work environments that build around healthy system design, and in doing so, help to mitigate burnout and foster a workforce that has well-being. In addition to those 5 elements, the committee looked at 12 different US and international systems that were implementing whole health-like models. Now, I think the committee would agree that it was not an attempt to find the perfect system, which had all of these elements included, so much as to find those that incorporated as many as possible and were exemplars. They included both domestic and international systems, and obviously included the VA. And really what it found was that while no single implementation instance demonstrated or even looked at every single one of the outcomes that were part of our 5 dimensions of whole health, across the examples, we could say that whole health implementations could show improved patient experience, better reported outcomes, increased access, reduction of ER utilization, fewer unnecessary hospitalizations, better quality metrics overall, improved outcomes for some specific conditions of importance, for example, pain management, mental health, healthy aging, reductions in maternal and infant mortality, and improved equity, as well as promotion to team well-being and some cost reductions. And some common themes that were found across the examples that the committee looked at included an implementation process tailored to those local environments, to those resources and community preferences, a basis on integrated high-quality primary care, which was deemed foundational to a whole health system, an effort to engage communities and not just the people who are actively seeking care, financing mechanisms that would pool risk. It also found that upstream factors are very difficult to integrate, and that team well-being, despite best intentions, is often neglected. And despite what we found in the public literature, or in the published literature, the overall systematic evaluations of whole health implementation were deemed to be scarce, making it really difficult to learn and evolve. I'm going to hand off to Sarah to continue the presentation.
Thanks, Andrew, and thank you to AIHM for inviting us for making this presentation. So you all just heard from Andrew about the examples of whole health-like systems across the US and internationally. And while they are promising and exciting, most people in most settings in the United States, including veterans who receive some or all of their care in the VA, still currently don't have access to what we're describing as whole health care. So to ensure that whole health is accessible to the entire US population, it has to be scaled and spread. So that was an important part of our task to understand how to do that. So, first, for purposes of a report, we differentiated between scaling and spreading. Scaling or scaling up was what we meant when we were talking about within a system, and spreading was replicating whole health models to other systems. With regard to what it will take to scale and spread, we highlight first that it will require a radically different mindset, from thinking downstream to thinking upstream, from thinking in terms of silos to thinking systemically, as well as unwavering commitment to the 5 foundational elements that you heard described before. Scale and spread will require new structures at micro, meso, and macro levels. For example, it will require interprofessional teams. It will require vertically integrated delivery systems and whole health ecosystems, by which we mean systems of systems that encompass and interconnect the capabilities and services needed in combination to provide whole health care. Scale and spread will require new applications of supportive processes, including decision-making processes around the application of evidence, teaming processes, implementation processes, learning processes, and social processes, a variety of them that shape new behaviors and shift power to individuals, families, and communities. Scale and spread will require integration across settings and services. And finally, supportive infrastructure will be needed to create conditions that enable the scale and spread. On the next slide, this figure here summarizes our vision for scale and spread. We encircled the familiar 5 foundational elements of whole health in the middle, with conditions and infrastructure needed to make whole health happen. At the top are a set of key contextual conditions that directly enable whole health. They include systems change and social movement needed to facilitate whole health transformation, structures and processes required for scale and spread, integration of silos such as health and social services, traditional and integrative approaches to achieve whole health. And then at the bottom are a set of critical foundational infrastructure needed to, so for example, to establish the information flows, for workforce training, education and well-being programs, measurement systems, and for both learning and accountability, and innovative financing. These 4 contextual conditions are supportive and indirectly facilitate whole health. All of these factors are depicted as puzzle pieces to indicate that they enable the scale and spread of whole health by mutually reinforcing one another. And then finally, with respect to scale and spread, the committee considered what the process of scaling and spreading whole health would entail. First, we'll need to anticipate that innovation will happen as systems learn to deliver whole health better. We should expect that and seek to learn from those early adopters, both within and outside the VA. Second, scale and spread processes can follow a variety of evidence-based models drawn from examples of implementing other health delivery innovations. And to be most successful, we suggest that individual systems and organizations should select and adapt processes that fit their local organizations and culture, because those will be different. There will be barriers, those are inevitable, and overcoming them will require both creativity and flexibility. Scaling within the VA is going to require attention to integrating upstream factors, integrating related and so far siloed benefits and programs of the Veterans Health Administration together with the Veterans Benefits Administration, and integrating VA and community services. And then more generally, for health systems to become whole, as the committee has defined whole health, will require scaling and spreading a variety of integrated services. These include integrated primary and behavioral health, traditional medicine with complementary and integrative health, medical and social needs, and new professionals, health coaches, health navigators, community health workers, and others into whole health teams, and all of this with the person and family at the center. Great. To ensure that every veteran and every person has access to and can receive the support that they need to attain whole health, the committee developed a set of recommendations that fall under 6 implementation goals. These goals apply to the VA system and more broadly to systems of care throughout the US. The goals describe a transformational journey through which health systems can iteratively learn to develop capacity for delivering whole health care. So goal number 1, commit to the shared purpose of helping people achieve whole health. Goal number 2, prepare for a whole health approach to care by self-assessing and considering what needs to change to be capable of delivering whole health care within your system. Goal number 3, transcend silos in order to integrate across systems, services, and time to support whole health care throughout the lifespan. Next, recognizing that the 5 foundational elements are interdependent. Goal number 4 is deliver all foundational elements of whole health care across the lifespan. And assuming we will need to learn over time, goal number 5 is evaluate to iteratively refine whole health care systems and create generalizable knowledge. And lastly, goal number 6, design public and private sector policies and payment to support whole health as a common good and whole health care as a way of achieving whole health. So we'll describe each of these goals and related recommendations in turn. I'll start and then pass on to my colleagues. So first, to achieve goal number 1, that is sufficient commitment to enable people to achieve whole health at a national scale. Our committee recommends first that all stakeholders from all relevant federal agencies down to the private sector should make whole health a core value. Making whole health a core value means committing to the goal of whole health and the cultural, structural, and process changes that are going to be needed to achieve it. The commitment has to start with leaders from both public and private sectors, and they need to take meaningful actions. We recommend a starter set of meaningful actions. These could include securing institutional prioritization and buy-in for whole health, naming the care delivery approach as a whole health approach, so we're all talking about the same thing, making a whole health approach part of the organization's mission statement, creating a vision and a roadmap for delivering whole health, including the people, families, and communities that will be served in the design of the whole health care system, financially investing in the development of whole health approaches, identifying local champions to lead transformation and support their efforts, and incorporating whole health approaches in day-to-day operations. So now to address goal number 2, I'll turn over to my colleague, Harold.
Thanks, Sarah. So goal number 2 is prepare for a whole health approach to care, broken into 2 recommendations. 2.1, national, regional, and facility VA leaders should ensure that all sites are ready to offer the whole health system of care to all veterans by ensuring that each site understands and adopts the whole health mission and vision, and has the resources and services it needs to transform its care delivery approach. As already alluded to, while VA has made tremendous advances in developing, implementing, and spreading whole health, not all VA sites, not even all the pilot sites, have fully implemented the program. Additionally, not all VA sites currently have the resources, including the needed cadre of trained interprofessional team members required for full whole health implementation. This may demand that these services be provided through virtual platforms or through non-VA community systems under the Mission Act until all VA sites are fully capable of delivering whole health to all veterans. Recommendation 2.2 really applies to other health care systems, community programs, social services, and public health organizations committed to helping people achieve whole health. And they need to ensure that all sites are ready to offer whole health care to the people, families, and communities that they serve. Now, whether an organization is first launching whole health or scaling and spreading the program to new sites, concerted efforts are going to be required to achieve transformation. And these include assessing organizational interprofessional team readiness, identifying potential facilitators and barriers, pinpointing those elements of the current system which require change, determining what resources are available and what's going to be needed to meet gaps, identifying sites that could be successful early adopters in this process, and designating champions to lead and redesign innovation and implementation, creating a sense of mission and urgency. In some reports from VA, these were essential missing pieces that leadership had this sense of mission and urgency that they were communicating and sharing throughout their entire program. Organizing interprofessional teams around the whole health needs of people, families, and communities. Developing processes for interprofessional teams and programs to collaborate, share information, and coordinate resources. Establishing mechanisms for dependable dynamic give and take with the people, families, and communities who co-create whole health. Developing clinical and social services, public health and community crossover partnerships needed to fully address all 5 foundational elements. And finally, ensuring that the whole health needs of the interprofessional workforce are also met. Goal 3, integrate across systems, services, and time to support whole health throughout the lifespan. 3.1, the Department of Veterans Affairs should integrate the delivery of whole health services between the Veterans Benefits Administration, VBA, and the Veterans Health Administration, VHA. And this would really be a paradigmatic shift in the way that VA is currently structured and operates. Many of the benefits which VBA, the benefits group, provides to eligible veterans already address upstream factors foundational to whole health, such as educational training and employment programs, as well as the enhanced capacity to build generational wealth through the VA home mortgage program. However, VBA and VHA are separate administrations under the Department of Veterans Affairs, with separate leadership, budgets, and reporting structures. Currently, their efforts are siloed rather than holistic. By seamlessly integrating and coordinating key VHA and VBA programs and staff efforts, VA can maximize the efficiency and efficacy of its whole health program while reducing health inequities among veterans. Recommendation 3.2, healthcare systems, and not just VA, should create and strengthen the infrastructure needed to partner with community programs, social care, and public health systems. These are elements of whole health that are traditionally in clinical settings seen as, we don't do that, that's not our table. Here's an address or a phone number to connect with those people. These things need to be fully integrated. This recommendation applies to both VA and non-VA. Even if VHA and VBA were to fully integrate their whole health systems, successful transformation is still going to require seamless coordination with a wide variety of community programs, social services, and public health components. And these are going to vary from community to community, state to state. Whole health systems require infrastructure that facilitates interagency cooperation and public-private partnerships at federal, state, and local levels. Each health system is going to have to identify local, regional, and federal resources and services, while at the same time working with their community partners to identify gaps in their current resources and approaches and successfully implement whole health care. Getting on to goal 4, which is to deliver all foundational elements of whole health care across the lifespan. Recommendation 4.1, the Department of Veterans Affairs should fully incorporate all whole health foundational elements into its whole health system. Those are the elements defined in this report, with particular attention to ensuring that care is comprehensive, holistic, and accessible to all veterans. Priorities include defining and addressing upstream factors which account for most of the variance in health outcomes, and then understanding that team well-being is essential to the success of both patients and health systems. VA must be accountable to all veterans and ensure equity for the disabled and socially vulnerable, including rural veterans, members of racial and ethnic minorities, and other subpopulations which face obstacles in accessing service. Additionally, VA needs to extend its whole health approach to women's health, reproductive health, family health, LGBTQ+ health, chronic disease management, and healthy aging. Recommendation 4.2. Health care systems, community programs, social services, and public health organizations should model whole health approaches after the Department of Veterans Affairs and other early adopters. Systems that are committed to helping people achieve whole health should begin by building on what others have successfully achieved. As VA advances its whole health transformation, it can also serve as a ready model for whole health in virtually every American community. Local tailoring will, of course, be necessary to address specific needs of people served and identify and optimize collaboration with and utilization of local care systems and community assets. Whole health should be the default mode by which healthcare is practiced in every community and across the lifespan. Finally, recommendation 4.3. Building on its existing health center program, the Health Resources and Services Administration, HRSA, should lead the scale and spread of whole health care in the community. HRSA is well positioned to serve as a federal leader in promoting whole health care adoption and implementation in non-VA settings. It has an established system of accountability and already addresses upstream factors which complement conventional healthcare. Particularly important is HRSA's demonstrated ability to scale and spread initiatives across the nation, for example, its federally qualified healthcare system, including some of our their work in some of our nation's most vulnerable communities through collaboration with state and community partners. HRSA's approach in promoting the uptake and delivery of whole health services will provide a practical model for commercial and federal payers, as well as state and local health departments from a respected federal partner. And now I'll turn it back to Jeanette.
Thank you, Harold. Goal 5 is to evaluate and iteratively refine whole health systems and create generalizable knowledge. Recommendation 5.1 says that systems fielding a whole health approach should systematically and continuously evaluate and participate in external evaluations of the implementation and adaptations of the approach and disseminate the lessons learned. Scaling and spreading effective whole health approaches so that whole health is accessible to all will take fundamental changes to the structure, processes, and goals of how the nation thinks about and cares for people. It is essential for public and private systems fielding a whole health approach to evaluate how to implement whole health care and its outcomes. Evaluations should be prospective, longitudinal, and multi-level. It should use a mix of methods and include information on how to achieve whole health. It should not be overly burdensome on clinicians or people receiving care. Findings should be openly and transparently shared so that others can learn and adapt approaches based on the results. These evaluations should focus on learning. It should be distinct from the evaluations used to ensure accountability and the quality of whole health care. Recommendation 5.2 says that building on its overall mission to study the care of people and the allocation of patient-centered outcomes research trust funding to disseminate evidence to practice, the Agency for Healthcare Research and Quality, AHRQ, should fund research to evaluate whole health care, as well as research that disseminates evidence on whole health practices. Additional research support will be needed from other national and international organizations, foundations, and private payers. To accomplish these recommendations, systems will need research support and funding. That's the message. And given its mission, AHRQ is the logical lead. The National Institute of Health's dissemination and implementation portfolio and new advanced research project agencies for health, ARPA-H, can also be applied to whole health care. Federal leadership from organizations such as the Office of the National Coordinator for Health Information Technology can create incentives for informatics vendors to develop and support the systems needed to deliver whole health care, to integrate collection and measurement tools into the electronic care delivery workflow, and to make data more easily accessible to care systems and health services researchers. Goal 6 is to design public and private sector policy and payment for support.
Next slide, Mark.
Design. So goal 6 is to design public and private sector policy and support and payment to support whole health as a common good. Recommendation 6.1A is the development of the Department of Veterans Affairs, federal policymakers, and regional third-party administrators should determine how the Mission Act applies to delivering whole health services. And I'm going to read recommendation 6.1B next, and then discuss this. Regional third-party administrators of the Mission Act should streamline the process for enrolling community providers in community care networks and define and enforce standards for health record transfer between community care systems and VA as a condition for reimbursement. While well-intentioned, the current implementation of the Mission Act is fraught with problems and is currently put into practice has significant limitations in access to care through community or non-VA clinicians. VA and federal policymakers are going to need to clarify which whole health services the current Mission Act legislation and policy covers, and then to hold regional third-party administrators accountable for establishing the clinical capacity needed to ensure timely, high-quality care. VHA and VBA programs should engage with non-VA health systems and social support programs to promote the routine identification of patients and participants with past military service, and then create coordinated care systems across VA and community settings in order to actually promote whole health. For the Mission Act to succeed, it'll have to ensure that there are sufficient networks of community providers and services in areas with unmet veterans' needs. While building larger networks of community providers will be challenging, regional third-party administrators can make the process of becoming an eligible community provider more efficient to attract more participants. They can also ensure that both VA and community systems have a complete picture of each veteran's whole health status, needs, and preferences by facilitating reliable and consistent health record exchange between systems. Paying for care from community providers and adding whole health care could not undercut access to services at actual VA sites. Now we will return to my colleagues Alice Prince to continue the discussion.
Thanks, Jeanette. And I'll just put another reminder in as we're finishing up our presentation that if you have questions to please type them in. So a common theme that you've heard throughout this presentation is that helping people to achieve whole health and delivering whole health care will take seismic structural and process changes and an unprecedented level of coordination at the local, state, and national levels. And this led to our last and critical recommendation, that Recommendation 6.2, the Department of Veterans Affairs, in partnership with the Department of Health and Human Services, should create a national center for whole health innovation to design and advance the policies and payments of whole health care. So currently, no one organization has the authority or responsibility for envisioning or leading this level of change. And the changes that we're recommending can't be accomplished in a few years. This really is a decades-long vision of change that we're talking about. This is why the committee felt creating and funding a national center is essential for change. In making this recommendation, the committee considered various entities to lead the effort, and we thought that the VA and HHS would be best positioned to lead the creation and design of the center, but it would take input from multiple stakeholder agencies throughout the process, like AIHM. And the center could be modeled after other national centers, such as the Centers for Medicare and Medicaid Services Innovation Center, and it would need a similar level of investment as these different centers. Next slide, Mark. Some of the tasks that the Center of Whole Health Innovation would need to do is to first disseminate and advance the vision of whole health. So take this report and what's been done by this committee and be a catalyst for change. The second task would be to define how to measure and hold systems accountable for success. So our current measures to define and show that our health systems are helping people are insufficient for whole health. They're grounded in a conventional biomedical model, and they miss the point of whole health. So we need to rethink these measures. The third thing they need to do is ensure that structures, processes, and infrastructure development that Sarah talked about at the local, state, and national level would occur. These are needed, and this is going to take coordination, and this is going to take planning. The fourth thing is to adapt value-based payment models. So the current payment model doesn't support whole health. It's grounded in a fee-for-service biomedical model, and it's partly why we're stuck in our current disease-centric model of care. So payment will need to be adapted and updated. And then fifth, we need to consider equitable allocation of resources. So how we allocate and how we distribute resources to promote health has to be fundamentally changed. And very specifically, we need more focus on root causes of poor health and a lot of these socioecological factors that contribute to poor health and poor health outcomes. So this leads us to the conclusions of our presentations here. So these recommendations, if we effectively implement them and will substantially improve and sustainably hopeful the health of veterans and the nation. And as we've said, whole health is a common good that benefits everyone, and it's something that we should all be working towards achieving. And scaling and spreading whole health will take cultural, structural, and process changes. It'll take multi-sector collaboration and investment, and it'll even take rethinking what it means to be healthy. And as a nation, we've invested tremendous amounts in treating diseases, and we've had tremendous success as well. But now is the time to equally focus on promoting health and investing in improving how we deliver care. This has often been neglected, and this report is meant to provide a roadmap on how to make these types of changes. So this brings us to the conclusion of our presentation today, and I believe that we've got 19 minutes to address questions and everything from the attendees about the topics that we've been addressing here today.
Yeah, we do have a question in the chat, Alex, and I'll read it out loud and then I'll type it into the chat box so everyone can know the answer as well. The question is, will you be including naturopathic doctors and functional medicine practitioners who are already practicing whole health with patients into these planning and oversight committees?
I think absolutely. So if you read through our report, integrative and complementary medicine is a key part of whole health and whole health care. I direct you to chapter 3, which talks about the different foundational elements and highlights all the evidence that Andrew talked about. And there's a component there about integrative and complementary medicine, as well as the other domains of whole health care, comprehensive whole health care. And if you look at chapter 5, which highlights the evidence of whole health systems, many of the systems have included components around this. So naturopathic doctors and functional medicine practitioners would be some of those stakeholders that are necessary to inform the future of whole health care design.
I think it's
And I would-
important to recognize, as I would add to what my colleague Alex has said, is that whole health is really based on a cultural competence model. It's designed to look at the needs, unique needs of the population being served, so that what the services that are offered can vary somewhat depending on where the model is being implemented. And I think you'll see that as Alex mentioned in our report. Sarah?
I was just going to add that also when we talk about scaling and spreading, the idea is that we would learn from models that look a lot like whole health in order to help others who are moving in that direction understand how to approach it. The other thing I would say, just based on what we know about how kind of change happens, given the amount of shift that's going to be required, is that when we're working with non-naturopathic, non-functional medicine practitioners who haven't been doing whole health in the way that we've described it in our report and in the way that you may be practicing, finding ways of bringing them along, I think, is going to really require both sharing what those who know how to do it have been doing, but also acknowledging the kind of best intentions and desires of the people who haven't been doing it, to make sure that they feel like the ones who know are being kind of helpful, as opposed to making them feel like they haven't been doing it right and should be doing it differently. So it will be interesting to see, as we bring these voices together on commissions to make this sorts of change. And we hope that we see that happening, but making sure that there is sufficient respect for all the kinds of providers and where they're at, in order to help the ones who need moving further along to make that shift.
Thanks, Sarah. We have another question in the webinar chat. Will you include independent providers who have an NPI?
Well, I think a couple of things just as a clarification here. I mean, the short answer is yes, this is meant to apply to all providers. And there'll actually be a paper coming out in the medical clinics of North America in September that's outlining different ways that individual clinicians and practices can move in a whole health direction. And when that comes out, I'd encourage people to read that, to think about what you can do locally. The purpose of this report, now on the broader level, this National Academies Committee is not assembling the people who are going to do all the things that we've called for. This report is a call for action. It summarizes all the evidence. What do we know and where are we at as a nation? It highlights some of the amazing work that the VA and other groups have done. There are 11 different examples that are put there about whole health demonstrations. And then it's really a call to different groups like these policymakers and others to make changes. And so one of the reasons that we want to be here and talk with you all is because groups like AIHM need to also try and talk about and promote that we want these types of changes. So this is a way that we can have a path to really encourage whole health as part of the conversation of where we should be heading as a nation for health and healthcare.
Thanks, Alex.
Alex, I was just going to add, since there's a theme here, the committee took teaming and the development of teams that are supportive of whole health as a real central charge. It shows up if you read the chapter on the dimensions of whole health in many, many places, and would strongly encourage anyone with interest to go to chapter 3. And you'll certainly see that we've all agreed whole health is a team sport, and we need to do a much better job from training to delivery reform to make sure that happens. So I think any questions about who should be included would be answered yes. It's going to take all the members of the healthcare team to achieve whole health collectively.
And if I could add, in our chapters on scaling and spread, we talked a lot about the importance of give and take between grassroots efforts and top-down kind of efforts, that it really takes both. And frankly, I'm more optimistic about us in connecting with providers of all kinds than I am with bridging the chasm between public health and clinical health, because we're natural partners and we don't read each other's journals. We don't talk to each other a whole lot. We use different words for the same thing sometimes, and that leads to confusion of tongues. There are so many ways to work together, but I really want to emphasize grassroots up, bottom up, as well as top down from state and federal levels, and organizations like a global organization like yours.
And I also agree that some of the confusion, in addition to what Harold has mentioned about the lack of cohesiveness and how public health and clinical health manage their different parts of the process, is we are not training diverse clinicians in the same space. And the whole concept, and this is something that's been discussed many times, interprofessional education, but we actually aren't doing it in very many places in the United States. So when folks have finished their training, they're thrown together and don't actually know the way in which each other's strengths can work together as a team. So for those who are involved in an academic environment, I encourage you to make sure that we get everyone who's contributing to whole health to also not only practice together, but train together, so we know each other's skills and the scope of practice well.
Thanks, Jeanette. Okay, I think we have answered all the questions in the chat and the Q&A. Again, unless anyone has anything further, actually we have one more from our, let's see if I could scroll up, from our fellowship director, Erica Capilouti. She said, as the fellowship director for AIHM's interprofessional fellowship program that trains providers in integrative whole health, self-care, education is of utmost importance to me and the organization. Is it reasonable to expect that funding will eventually be made available to support those who wish to pursue this formal education as part of the whole health initiative?
I can start. As part of the infrastructure that we said needed to be created, we paid a lot of attention to workforce and developing a workforce that could practice this kind of that could provide this kind of whole health care. And as part of it, so we definitely called for training along these lines. That would imply that necessary funding in order to provide that training. Whether it will happen or not, we can't say, but the hope is that there would be funding for it, and the attention to the need for it was definitely called out. So we're on your team when it comes to funding for training, for sure.
Well,
and I would echo what Sarah's saying, in that you'll notice that we've called out a lot of people. We called out federal agencies, we called out the private sector, we called out communities, because everyone is going to have to do some part of that. And when it comes to training, the federal agency that really supervises and funds the majority of training is HRSA. And so I think for those who have specific contacts in each of these different agencies, that's where you have to be advocates for getting programs for that. But there is no way that whole health will be implemented within one sector alone. It's going to have to be comprehensive and across a variety of disciplines.
Well, I'll add, I think it's in chapter 7, we give examples of whole new disciplines that VA has created. And, being a federal agency, they couldn't just say, hey, you go do that. They had to create position descriptions, definitions, training programs. And these programs can be used by others. And just as one example, especially in the last 20 years of war, VA has developed a huge pool of peer support specialists and certification programs at community colleges to train them. This is a discipline that didn't exist before. I know as a doctor, when one of these folks appeared in my clinic, I was wondering, who are these people? And do I want to trust them with my patients? And are they going to make more work for me or less work for me? And I learned in practice that these guys were terrific, men and women. and they were doing things that I didn't even think to do, and they had more time. And patients, especially veterans, could talk to them differently than they feel they could talk to a doctor, even a doctor they liked and trusted. So you'll find examples of how this is done and models for how it can be done for other disciplines that are going to be needed as we scale and spread whole health.
I just noticed a comment from Alyssa, and I wondered if I could ask you to say more. We'd love to hear about some of these initiatives that are underway.
I am able to allow her to speak. Hold on, let me just go into attendees. Okay. If she's hearing that,
With apologies for cold calling.
that's okay.
So,
Go ahead.
this is Lisa, and I am hoping I'm not on view.
You're not.
Excellent on a Friday afternoon. So I am the outreach consultant for the International Somatic Movement Education and Therapy Association. I am the most recent former executive director. I just retired a week ago. And I'm staying on as outreach coordinator, but some of my work as executive director included participating in the National Center for Complementary and Integrative Health's stakeholder meeting, specifically on whole person health last October. And they spoke about the excellent work that you were doing at the VA at that time. We were all looking forward to receiving your report, and it's exceptional. It's exceptional work. Thank you so much. So we had that stakeholder meeting, and at that stakeholder meeting, the call out was, so are you people who are here, and there were about 100 of us, maybe a little more, all sectors. We were asked whether we were willing to put aside our individual agendas on behalf of the whole and moving forward with this charge of whole person health. And wouldn't it be nice if you developed a coalition on whole person health that could work very closely with us? We, NCCIH, cannot create this coalition, but if there were a group of people who are at this stakeholders meeting wanted to develop that coalition, we would love to work with you. So a group of people got together to try and begin the process of drafting just draft purpose statement, what it could kind of look like, how we could function, etc. And we're in process. And I see Margaret Chesney there, also made a comment right there, and she's in that group. So I'm in the group, Margaret's in the group. It was just a group of people that came together and said, let's write this up. And then we'll call together a big meeting of everyone who was at the stakeholders meeting and anyone else we can think of, and then start organizing around this coalition.
Great, thank you.
And
thank you also to Margaret for her contribution as a member of our committee.
Yes, and Liza Goldblatt is participating in that group, and I can't remember everybody's name because I'm kind of the newbie, but they're great people that are there. Just we'll put something together and then get it back out, and it's very exciting. This whole person health initiative nationwide and globally is just fantastic. Thank you for your good work.
It's so good to hear about what you're doing. And, I've gone to some meetings after the report was published with senior heads of Veterans Benefit Administration, some people from CMS, and I was actually a little worried, that we'd gone too far. They were, what's wrong with you people? Don't you know we don't do this, that? And in fact, they were telling me, oh, we've been thinking about stuff like this, and your report really helped us think, take it to another step, maybe. I wonder if we asked for enough, but I think we asked for what's needed.
I think we asked for enough, Harold. We asked for a lot.
All right, it looks like there are no more questions within the chat, and on the Q&A, and we are just at the hour, which is actually perfect timing. So I just want to again thank everyone from National Academies and the representation we had from the VA as well. And just remind everyone that again, this webinar, as all of our webinars, are going to be on YouTube, and then this is also going to live on our LinkedIn page. So there's a ton of ways you can go back and rewatch this for information. And we want to thank everyone who joined, and we hope everyone who celebrates has a wonderful holiday and a safe weekend, and we will see you next time. Thanks, everybody.
Thank you all.